Hi, everybody. This is Lisa Hurley from Fulcrum Aesthetics. So happy to be here to talk about the menopause transition. It looks like we're waiting for a few people to join. So let's give it just a minute. Can you guys hear me okay? Awesome. Oh, we got 11 people, 12. Good. Okay, well, it's 12:01, so let's get started. So I want to talk to you about something that is really near and dear to my heart, and that is the transition into menopause. Um, I am Lisa Hurley, nurse practitioner. I'm also a certified menopause specialist. I am a member, these are disclaimers, I'm a member of the North American Menopause Society, now named NAMS, and a certified menopause provider. As I said, I'm also a postmenopausal woman, so I do have a perspective. A couple of terminology points I want to go over because it's pretty confusing. People talk about perimenopause, menopause, postmenopause. So let's just talk about it for a minute. Perimenopause, there is no consensus. It can last between 4 to 10 years, but I've seen estimate of up to 15 years. Menopause itself just means that you are no longer having periods. It's cessation of menses. Early menopause, this occurs at an age prior to 45. Late menopause occurs after the age of 54. Now, induced menopause basically is loss of ovarian function for a few reasons. Could be surgical, or sometimes we have no idea why it happens. And the definition of postmenopause simply means that you have not had a cycle in 12 consecutive months. The median age right now in the US for women is about 52.5 years. I will say this is a natural process, but that sounds trite. Yes, it's a natural process. But so is impotence, so is eventual high blood pressure or elevated lipids as we, get older. That doesn't mean we don't treat it. It's just that you shouldn't feel like you are abnormal or this isn't something that happens, through a course of time. In the United States, it's been very undertreated for many reasons. Of course, the stigma. For many of us, we don't want to talk about this thing. It's a very private matter. Or as women, we've been told that, just suck it up. This is something that's happening. And really, there's a lack of study on women in general, a lack of education for providers, for women. And one of the biggest culprits was the Women's Health Initiative study, the WHI study, when they reported their information in 2002. Now, the study started in about 1990, so they had a lot of data. But when they came out in 2002, the information was pretty scary for people. And for most women and providers, we stopped using hormone replacement therapy at that time. The study itself looked at synthetic progesterone and oral conjugated equine estrogen, the mare's urine. And the women who were primarily studied, average age was 63. At that time, they estimated that about 40% of women were on hormone replacement therapy, which is huge numbers compared to now. I looked at some data that suggested in 2025, they were just looking at insurance data. So we don't have information on women who are using compounded hormone therapy, but it was less than 5% because of the scare of the results of the 2002. So when they initially brought the data out from the WHI study, it was misinterpreted They reported that breast cancer was, rampant in women who are using hormone therapy. And at that time, providers got scared, women were terrified, and everybody just stopped using it. It's taken a lot of years from then till now for us to really get the news out that, first of all, this information was completely misinterpreted. And even the people initially interpreted it said, really, it was not even statistically significant. And if you were utilizing bioidentical hormones, probably not relevant at all. So it set us back a lot. And there's a lot of women who suffered because of it. So let's jump into perimenopause first. Perimenopause is poorly understood and it can be complete chaos. I have listed puberty 2.0. That's not my phrase. I have seen a couple of people on social media that utilize it. Kelly Casperson, who's a urologist, use it. Love that definition for a lot of reasons. There's a phenomenon that happens during perimenopause. It's called the loop phenomenon, luteal out of phase event. Basically, to break it down, as estrogen declines, your body wants to produce more. So FSH, follicle stimulating hormone, rises and it's trying to stimulate your ovaries to release more follicles. And that typically happens. You can have multiple follicles. If that occurs, you actually have an increase in estrogen. And so if you took blood work at that moment in time, it might even look like your estrogen's high or normal. So you can't rely on it. You also could potentially, if you got pregnant at that time, have multiples. So you need to keep that in mind. Also, during that time, if you have elevated estrogen, a lot of women then start feeling bad, or they have a lot of tender breasts, worsening migraines, fibroids start to grow. That's when they really start saying they have the emotional roller coaster, crying, angry, they want to hurt somebody. It tends to be in the second half of your cycle. Classic symptoms that we talk about, irregular cycles. It could be shorter, longer, spotting in between. And that's when we start to have the vasomotor symptoms. That's the hot flashes, the night sweats, insomnia, depression, anxiety, moodiness. You have some vaginal dryness or pain with sex or decreased interest in sex. Other things that women report could be joint pain, dry eyes, starting to put weight on in their abdomen despite nothing changing in their diet or their exercise routine, brain fog, difficulty concentrating. How do we assess this? Really, because of the loop phenomena, because we know that your labs aren't necessarily accurate, it's really about your symptoms. We need to talk to you individually. What's going on? Do like to have baseline labs to ensure there's nothing else metabolically going on. Once again, you can have a normal follicle stimulating hormone, FSH, until late into perimenopause, or by the time you're into menopause or postmenopausal, it will definitely be elevated as estrogen deprivation occurs. So you'll see elevated FSH and a decline in estradiol. Once again, actual menopause is during that period of time when you're no longer fertile, you're not having periods, and once that's occurred for 12 consecutive months, then you're postmenopausal. That's when your symptoms will really get worse. Very individualized treatment. Depends on what we're trying to treat. I've had women who say, yes, I have no libido, but I don't want to do anything about it. Or it's really my lack of energy or my poor sleep. So we need to really delve into that and then find a treatment protocol that will work for each individual. Types of estrogen, there's multiple types of estrogen. There's estrone E1, estradiol E2, estriol E3. Estradiol is the strongest, and that's the most prevalent during a woman's reproductive cycle. And most HRT is estradiol. However, there are some that combine estradiol and estriol. There's also topical ointments that are just estriol. It all depends. We've got a lot of options. How can it be delivered? Multiple ways. You can have oral estrogen, vaginal suppositories. You can have rings, um, topical creams, patches, transdermal patches. The patches are weekly or semi-weekly. For some women, they can be sensitive to the adhesive they use. Then there's pellets and injections. Now, some of the pros and cons: oral, you can take it daily. That has increased risk for thrombus or blood clotting if it's going to happen. And for people who have underlying clotting disorders, you should not be taking oral estrogen. You could then talk about transdermal because it bypasses the liver metabolism and is considered to be much, much lower risk of any type of clotting disorder. The topical creams and patches, you can get creams for your face that will help with fine lines and wrinkles. That's typically well tolerated. But if you're utilizing it for hormone replacement, it can be pretty messy just because of where you put it. And you don't want to transfer it to children or pets. Injection, self-explanatory. Pellet insertion, absorption can be irregular. And once a pellet is inserted, you can't take it out if you're having symptoms. If you start estrogen therapy, say you have a lot of breast tenderness or breakthrough bleeding, if you're on a patch or a pill or a cream, you can stop it. But with a pellet, you can't remove it. So one of the things you need to consider when we're discussing your own personalized treatment. Types of progesterone: synthetic, like the one that was in the initial study. And also you can have progesterone in used as a contraceptive or IUD. We use that a lot, like a Mirena. We use that a lot in women who have dysfunctional uterine bleeding, and that works great. Or endometriosis, it can be very effective. What's considered natural or bioidentical just means the chemical composition is most similar to what your body produces. Some could be derived from plant sources, but right now, micronized progesterone is the most recommended because of bioavailability. And that is oral. Testosterone, another hormone that we make. We make estrogen, progesterone, and testosterone, as do men, just in different varying degrees. We, as women, produce about 10% of what a male produces. And when we're doing replacement, we're kind of going by the same theory. Testosterone for both men and women starts to decline after the age of 30. And it's usually a slow decline. It doesn't just drop off like, estrogen or progesterone. But testosterone is a great hormone. It can help with overall energy, mood, sleep, libido, ability to maintain muscle mass, prevent osteopenia, osteoporosis. Some of the downsides: testosterone is the one hormone that you really have to watch your blood work after you start, because it can increase your hemoglobin and hematocrit and put you at a higher risk for a blood clot stroke. So if you start testosterone therapy about 6 to 8 weeks after you start, however you choose, creams, injections, pellets, you need to have your lab work rechecked. And then, of course, acne, hair growth, you could do laser therapy. Some women have a big increase in libido with hormone therapy, and some have a lot of mood swings. Once again, you can do it the same way: creams, gels, injections, or pellets. I would never suggest testosterone therapy, first-line therapy for women for pellets. I would say we'd start with cream and gel until we were sure that you liked the benefit, if you felt it was really, helped your quality of life. And then we could talk about whether or not pellets would be appropriate for you. And the same with estrogen or progesterone or any type of cream. You have to be very careful, if you're using topical, that you don't transfer it to small children or pets. Now, osteopenia, osteoporosis, bone loss. So osteopenia would be the beginning stages, thinning of bone. Osteoporosis is when you actually have structural, you can see structural damage. 35% of postmenopausal women are affected by this. Strength training, hormone replacement therapy can really help prevent it. You got to make sure your vitamin D levels are adequate, as well as collagen that can help prevention. Interestingly enough, estrogen is FDA approved for the prevention of osteopenia, osteoporosis, but not the treatment. There really hasn't been a lot of study on it, but it would make sense that if you are suffering from this, that you would want to consider hormone replacement therapy. There's many syndromes that occur as estrogen deprivation occurs. There is with frozen shoulder, happens a lot in women in their 50s, very understudied. Joint pain across the board tends to increase, and that's all your joints, your shoulders, your elbows, your knees, your ankles, everywhere. Estrogen itself is very anti-inflammatory, and we think that plays a big role because for most women who have joint pain associated with estrogen deprivation, once you start hormone replacement, you have a big improvement in your symptoms. Also, there is some correlation that if you do not start hormone replacement therapy, you do have increased risk for osteoarthritis. So that's kind of sobering. There are GI symptoms that are associated. You have estrogen receptors throughout your body, from the brain, through the all the stomach, your colon, everywhere. So some of the things that women can experience as they're going through perimenopause: constipation, changes in bowel habits, diarrhea, nausea. Some of the things that you can do to try to prevent these: fiber. Fiber is queen. Especially once you're in a menopause, you should be getting at least 25 grams of fiber daily. You should shoot for more. Fiber is one of those things you want to start slow because it can cause bloating and cramping, but you build a tolerance and try to go a little higher. Of course, natural foods are the best. Fermented foods, absolutely. Kimchi, sauerkraut, but there are other supplements you can take. You can take powdered form. You can add to your coffee. You can take, tablets. Whatever makes sense to you. Raw foods, raw vegetables. There's also genitourinary syndrome that occurs with estrogen deprivation. Unfortunately, the loss of estrogen affects everything. The lining in your vagina, the skin gets very thin, friable. You have an increase in your pH, changes in odor, just a decreased lubrication. So you have more painful intercourse. Women can have pain just with clothes, let alone with any type of examination. Very uncomfortable. Some women actually to the point where they can't handle any type of wiping after urination or defecation. You should be on vaginal estrogen. That should be part of your treatment protocol as you go into menopause. You need to stabilize that tissue, because what we now understand is that as these changes occur, you're also at higher risk for urinary tract infections because of the change in pH. And we know that as we age, urinary tract infections, unfortunately, especially when you get over 70, can cause confusion, increased risk of fall. And we know that both women and men, if they fall, say they break a hip, they have a very poor recovery. I mean, that's nowhere you want to go. So this is something to think about as we age. And as you start having hormone replacement therapy, protocol plan, include vaginal estrogen. And it can really help with the decreased libido and pain with intercourse. Also incontinence, that occurs with estrogen deprivation. So there's a lot of treatment options. I want to go over a couple of them. Lubrication, of course, a vaginal moisturizer, vaginal estrogen, vaginal DHA, pelvic floor therapy. There's a CO2 lift B, MCELA, which is a pretty incredible device that induces about 11 to 12,000 supramaximal pelvic floor contractions. This is equivalent to like 11,000 Kegel exercises. That's over 28 minutes. It's really impressive. So a treatment protocol for this, it's 3 times a week and 2 weeks, and it can make a big difference just to help strengthening your pelvic floor. And you should be using this with your vaginal estrogen, with your moisturizer and lubrication. 6 treatments, that's 3 a week. That's what it's about $2,400. That's our protocol here at Fulcrum. 3 treatments the first week and 3 more the second week. So we love it. I keep trialing it. I keep seeing the literature. I'm really impressed. Results typically develop after a series of treatments. And I've had patients tell me after 1 treatment that they've had improvement in their symptoms. Now we're going to talk about what hormone therapy can do for cardiovascular system. We now know that CEE, which that's actually the mare's urine, the conjugated equine estrogen that initial study was based on, both monotherapy and in combination with progesterones, had an overall favorable effects on cardiovascular biomarker. This says with the exception of triglycerides. I've seen a lot of reduction in triglycerides and lipid levels after women start hormone replacement, though, just in following their lab work. So we know that women will benefit if they start hormone replacement therapy earlier rather than later. I would suggest within perimenopause. If the longer you wait to start, the less benefit obviously you would get. And that's when you see more complications in some of the subsequent studies that they've done. I think it's simply because they followed women who didn't take hormone replacement. They didn't have that extra protection. So when they finally started studying them, they already had, some type of cardiovascular issue already building. Also, measurements of insulin resistance definitely decreased, were reduced by at least 14% just with the CEE, the conjugated estrogen alone, and also with the addition of progesterone. Also, lipoprotein A and little a was decreased by 15 to 20% with hormone replacement therapy. Talk about skin changes. There's all kinds of changes that occur with, once we start losing estrogen as we age, also collagen, thinning, loss of elasticity. We can do a lot of things. We have skin pads here. It's got the GHKCU with hyaluronic acid, the copper peptide. Medical grade skincare should be top on your list. Also facials, lasers, neurotoxin, collagen stimulators. We lose so much collagen. And of course, fillers. Then we also can get compounded estriol with copper peptide and hyaluronic acid. You can see a big difference in your fine lines and wrinkles using topical estrogen. When should you stop hormone replacement therapy? Now, there's a lot of controversy. Initially, there was a lot of literature that suggested you should only be on it for 10 years and then stop. We really do not agree with that anymore. There are multiple studies that are still ongoing. In fact, the WHI study has multiple arms and they're still following women now. But one of the research on 10 million Medicare, that's 10 million Medicare recipients that went from 2007 to 2020 showed significant reduction in risk in a bunch of cancers, blood clots, heart disease, including ischemic heart disease, ovarian cancer, with hormone replacement. So right now, the implication of HRT use beyond the age of 65, it varies. Depends on how you take it. Like I mentioned before, if you are taking oral estrogen, probably should switch to a transdermal, some topical, so you can avoid that liver metabolism, and that would help decrease risk for cardiovascular, like a stroke, cardiovascular issues, or thrombus. Additionally, if you start it earlier, the risk seems to go down for any of these side effects that could occur. And if you use lower to medium dose, meaning what they found is that if there were any side effects, it seemed to be when you were utilizing higher dose of hormone replacement therapy and you started it later after you've already, into menopause. Once again, another possible study is that menopause patients should start or use HRT beyond the age of 65. We now think they should, but it's case by case. It's very individualized, meaning if you have underlying active cancer, especially if it's estrogen sensitive, you should not. If you have really serious cardiovascular disease, it's got to be evaluated case by case. But we know that especially the use of estrogen and progestin can really actually lower the risk of breast cancer, endometrial cancer. All types of postmenopausal hormone therapy do appear to confer some type of benefit. This particular study showed the significantly lower risk. We talked about fractures, significantly lower risk for fractures. And the fractures were related to osteopenia and osteoporosis. That was with unopposed estrogen and estrogen progesterone. I do want to say that I didn't mention earlier, and we'll mention it later, is that if you have a uterus, you have to take progesterone with estrogen. You can't take estrogen unopposed. That could lead to some, unfortunate issues with endometrial hyperplasia. The lining of the uterus gets thicker, cells could change, and then there's concern that it could develop into, some type of a malignancy later on. Or, you could have abnormal bleeding. So if you're taking estrogen and you have a uterus, you need to take some type of progesterone as well. So potential adverse effects, that's when we started, could be abnormal bleeding. You could have spotting. You could have been, without a period for 12 months. We start on hormone replacement, and then we start noticing some uterine bleeding. Could have breast tenderness, enlargement, abdominal bloating. Fluid retention is, one of the well-documented with hormone replacement that usually stabilizes. Headaches, dizziness, mood changes. And then, of course, if you have angioedema, that's allergic reaction, you've got to stop it. There have been some reports of pancreatitis and gallstones, especially with testosterone, increased facial hair or some decline of your head hair. Usually that's dose dependent as well. Typically means the testosterone is too high. Also changes to the shape of the cornea, rare, but it could happen. Who should not take hormone replacement therapy? Touched on this briefly, but anybody who has a history of pulmonary embolism, DVT, active thromboembolic disease, liver dysfunction. If you're pregnant, absolutely not. If this Purpurea cutaneous tardis is a really very rare disease of the skin with blister and fragile epidermis, you wouldn't take it. Any type of neoplasia, a cancer that is estrogen dependent, metastatic disease, or any, if you're having bleeding, genital bleeding, and we don't know why, you should stop all hormone replacement therapy and make sure you get ultrasound, make sure you don't have a fibroid or anything else going on. I did want to point out that the North American Menopause Society position statement, it still is very cautious for women who initiate therapy, hormone replacement therapy, more than 10 years after menopause onset, or they're older than 60. The benefit to risk ratio appears less favorable because of the absolute risks of coronary heart disease, stroke versus venous thromboembolism and dementia. we're still really evaluating that. I would say that once again, it's very individualized. We've got to look at your own personal risk versus benefit, and that's very individualized, and go slow, you know. So take home, number one, you got a uterus and you're on estrogen, got to take progesterone. That is an absolute must. You can take it multiple different ways. Micronized progesterone is preferred. That's oral. Take it at night. It also is a great sleep aid, sleep well, and great mood stabilizer, as well as just a great overall hormone. If you do have a clotting disorder, oral estrogen, it's contraindicated. However, it's very possible that you could still take a topical like vaginal estrogen and possibly patch. Pretty much we'd have to talk to hematology and just make sure, what type of bleeding clotting disorder you have and if it's appropriate for you. If you're using any form of testosterone, you got to have follow-up labs. I really think for most women, once we evaluate what's going on in their life, what the potential benefits could be for hormone replacement therapy, that the benefit outweigh the risk for most, not all. At the end of the day, everything in life does have risks. You've got to evaluate what the benefits would be versus the risk, and make an informed decision if it's right for you personally. And then, you ready to feel like yourself again? I wanted to just mention that fewer than 1,000 providers hold this credential nationwide, the MSCP. That is through the Menopause Society. You can go on their website and look for providers that are certified to see if there's one near you. If you're in the Chicago area, I am. Our consultation includes blood draw as well as lab interpretation, so we can actually look at it, we can talk about it, and then we talk about your symptoms and what we might be treating and what the potential benefit versus side effects. We would exhaust coverage with your insurance, meaning if you have health insurance and we want to start you on transdermal patches or micronized progesterone, I'll send it to your retail pharmacy first. I will tell you though that testosterone is a whole different game. For women, it's typically we have to go through compounding pharmacy. There's no woman titrated formulation that's available retail, especially through pharmacy. You end up getting like little packs where you've just got to squirt a little pack out, like a little dab, and try to utilize that. It's one of the reasons why I really prefer compounding pharmacies. They end up, at least you can just do like one pump, just makes more sense. When we do use compounding pharmacies, they are FDA approved facilities. Pure encapsulation, we have pharmaceutical grade supplements that we can also recommend to you. We have this little food program, hormone supportive nutrition, that you can utilize just to help with your overall health journey. So the consultation, you can get $100 off the initial consult. An hour with me, we'll do the blood draw. We follow up about a week later, discuss the results. Prescription plus or minus, depending on how we choose to move forward. And this offer through the end of the month. So book your consult. Reference section. And I want to thank you for allowing me to talk about this. This is something that everybody should know. And, it's not just for women. In your life, you love a woman, right? I mean, you either have a sister or a mother or a daughter or a friend or yourself who either has gone through this, is going through this, or will go through this. So stay tuned for next week. We'll discuss how to prepare for plastic surgery with Nikki and Howie, who's our surgical care team. You can utilize the scan there for a V bundle, plush skin pads, balanced facial moisturizer. And shortly here, we are going to go to our questions. Okay, so are injectable self-administered? Are injections self-administered? Yes. Yeah, they are. I'll teach you how to do it. You can bring your product in. I'll walk you through it. But yeah, self-administered at home. Rachel, would GLP-1 or specific peptides help? Yeah, I've had great success, especially with GLP-1s in women in perimenopause and women who are fully menopausal who weren't ready yet to start hormone replacement therapy. And there's actually studies that show the combination of a GLP-1 with hormone replacement uh, give the maximum benefit, with not only weight loss, but improving insulin sensitivity and just general feeling better. What do I think about the Mona Lisa vaginal rejuvenation? I don't have enough information to answer that, honestly, to give you a good feedback on that one. How soon can you get your medications after I meet with you? I'd want to see your lab work, but I could order it at that point immediately. So that would depend on if your medications are coming through your retail pharmacy, through compound pharmacy, or if you're doing a GLP-1, we tend to go through Eli Lilly. If it's tirzepatide Zepbound, it comes directly from them and shipped to your home. And they're typically within, usually somebody is within a couple days to a week. Some of the compounded medications, however, can be a few weeks, especially the topical estrogen cream. They don't have it sitting on the shelf. So once it's ordered, they make it specifically for you. Tasha, do you have to stop your estrogen progesterone for the blood draw? No, don't stop it. I want to see where you're at with, with what you're taking now, because we can evaluate it. Oh, talk about the difference between HRT and birth control pills. Actually, I'm glad you brought that up. You know, it's funny that we became so terrified of hormone replacement therapy when birth control pill, they have a higher level of hormone, and those are prescribed like Tic Tacs. Can you start HRT with a uterine polyp? It's not contraindicated, but it has to have had been evaluated, and you have got to be committed to monitoring it. What's my preferred way to take testosterone? I like pellets. They're easy, personally. But if you've not taken testosterone before, I would prefer you start with topical because you don't know how you're going to react. Let's see if you like it, how you respond, because everybody metabolizes medications differently as well. If for example, you wanted to say, I want to start testosterone, I want a pellet. Well, what if the level's too high? A couple of things happen. Really high testosterone, as I mentioned before, can increase your risk for blood clots. It increases hemoglobin hematocrit. It also converts then to estrogen, which you can have a lot of symptoms associated to that. And yes, we have ways to treat that, but I'd rather be cautious and go slow. HRT help with weight loss. Yeah, yeah, it does. It also helps with women's LDL elevates as estrogen deprivation occurs. And I've seen multiple women, they're doing everything right. They are really monitoring their intake, they're eating clean, they're exercising, but their LDL is rising. They start hormone replacement and go back to a normal level. It doesn't happen for everyone, but we know this is a known fact that your LDL will rise as you go through menopause due to estrogen deprivation. So for those women, they don't really respond to statins well. Hormone replacement should be part of your protocol. Any concerning side effects for tirzepatide? Yes. So the GLP-1s, actually, that is semaglutide's a GLP-1 by itself. Tirzepatide's GLP-1 with the GIP and tends to be better tolerated. So some of the side effects, of course, first of all, you have to not have a genetic thyroid cancer in your family. That's a black box warning. For most people, they don't. But side effects could be pancreatitis. You've got to monitor that. Constipation is a real issue. That happens more so with semaglutide than tirzepatide. Additionally, you have to make sure you're eating and really being conscious of protein intake, because there are people who just stop eating, become very malnourished. You have a lot of muscle wasting if you're not cautious. So I'd say that's the biggest thing with tirzepatide or semaglutide is you've got to be conscientious of what you're feeding your body. You've got to really be on board with going slow weight loss, so you're losing fat, not muscle. But most concerning would be if you had gallbladder, pancreatitis, something like that that occurred. It doesn't occur often, but it could occur. What's the difference between seeing me versus an OB/GYN for treatment? Well, first of all, I'm awesome, so we'd have a good time. But all kidding aside, not all OB/GYNs have been trained or are comfortable with menopause therapy. It depends on where they're at in their career, if they're interested in further education. I would say have a discussion with your OB/GYN. If they're open to it, if they're like, yep, I know the benefit, I know the literature that's out there, then by all means. If they say, nope, just suck it up, I would say seek another OB/GYN or go to the menopause website, find a certified provider, or come see me. I'm almost 40. Do you recommend taking collagen peptides such as vital proteins now? Yes. Yeah, you're already having collagen depletion right now. Not really aware of any risk factors aside from if whatever you're taking, you have some type of, reaction, say it's whey protein, or whatever is mixed with it. But yeah, you should start collagen sooner rather than later for multiple reasons. Skin, bone. So what's a good starting dose for topical testosterone for a female? It is so varied. Depends what your initial levels are. 5 milligram to 10 milligram. Remember that we utilize about I shouldn't say utilize. Women's dosing is about 10% of men. So I would say they're 5 to 10 milligram daily, and then monitor, because some people really respond quickly and or slowly, and then we've got to increase dosing. Very individualized. Yes, hormone imbalances can absolutely affect cortisol, as well as moods. One thing I didn't mention, and I want to kind of flip back to, is as I was reviewing some literature for this talk, the Federation of Gynecology and Obstetrics recommends that women who develop depression or anxiety during the perimenopausal time, that they shouldn't get started on antidepressants. That first line therapy they recommend is hormone replacement therapy, because we now know that like over 60% of women going through perimenopause are gonna feel depressed. They're gonna have anxiety. That's sometimes some of the first symptoms they have. So we should be doing hormone replacement therapy first, and then reevaluating. Of course, there's a lot of other things, like if they have a long history of depression, that would change recommendations. Okay, it looks like that's all the questions that I have. Once again, I want to thank you so much for attending, and I hope this was valuable.